Welcome to Key into Quality, the Mayo Clinic podcast, where we explore the people, practices, and principles that elevate healthcare quality and safety. Thanks a bunch for joining us. I'm Dr. Tim Morgenthaler, professor of medicine here at Mayo Clinic and a vice chair of Mayo Clinic Quality. In this episode of Key into Quality, we're returning to a powerful story, one that started with a somewhat startling realization. At Mayo Clinic Arizona, 2/3 of workplace violence assaults had involved confused patients. Behind those numbers were moments of trauma for staff and missed opportunities to support patients who were in distress. Today, we're going to hear how a team moved forward from this insight to action, building practical tools, reshaping workflows, and ultimately improving both safety and care by addressing delirium head-on. Co-hosting with me today is Sherry Nemec. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. And as Dr. Morgenthaler was saying, today we are going to continue with part 2 of our podcast series on delirium.
Yes, so today we're going to hear from the team that took this problem from its initial beginnings in Arizona a little more broadly. We're going to have a wonderful time just talking with them how that actually has transpired. Let me see if I can introduce our guests. We're really thrilled to welcome 3 outstanding colleagues to this episode, each bringing, I think, a pretty unique perspective. Joining us from Phoenix is Jennifer Sweilem, who is a nursing manager in the Department of Nursing. Jennifer brings a wealth of frontline leadership experience and a passion for advancing patient care through team collaboration and innovation. Also from Phoenix, we have Nicole Lies, who's a quality performance improvement advisor with the Systems Quality Office. Her work focuses on driving measurable improvements in care delivery, and she's been instrumental in several cross-functional initiatives aimed at enhancing patient outcomes. And finally, from Rochester, we're joined by Dr. Heidi Lindroth, who is a nurse scientist in the Department of Nursing. Dr. Lindroth brings a research-driven lens to our discussion. So together, I think we're going to have a great conversation, and maybe I could just start by asking Heidi, would you be willing to just tell us a little bit about yourself and how you came to this role at Mayo Clinic?
Yeah, absolutely. Happy to. Thanks for having us on. It's really exciting to be part of this podcast. So my vision is a world without delirium, and everything I do in research or clinical care is trying to move the needle towards that goal. The way I arrived at that vision, I think many of us have stories about delirium, about either loved ones or friends or neighbors that we know who had delirium and we had to witness it, or we see it as clinicians and have had to, watch patients and families suffer through it and also deal with the behaviors that come with delirium. And when I was a PhD student, I, was very into neuroscience. That's what my PhD is in. I wanted to really get into like the brain, like the reason why delirium happens. And I didn't expect, actually. I wanted to work kind of in a lab setting or do more biomarker basic science work. But I had this one participant who underwent a really complex surgery. It was elective. It was supposed to make him better. Of course, he had complications, ended up in the ICU for 4 days, deeply sedated, and then had severe delirium for 10 days after the ICU. And he also had agitation with clinical staff. And we would see them twice a day as a research team. And it was the most severe delirium I have ever seen to this day still. And there was one day, about 5 days in, I walked into his room and he sat straight up in his bed and he made eye contact with me for the first time since before his surgery. And he shook his finger at me and he said, "I know that you know the answer to this. Will my brain ever be the same? Will I ever get back to normal?" And it still gives me goosebumps when I tell the story. And back then, I broke down crying because I knew the likelihood of the answer. And so when I saw him a year later to do his research visit, he could no longer do simple math and he couldn't remember the day of the week and had to cancel his retirement plans to travel around the country in his RV. And it crushed me because when I looked back at his medical record, no one had even documented delirium. And it really shook me because I'm like, if I'm going to get a PhD and do all this work, I really want what I do to actually touch a patient. I want it to impact clinical care and make it better, not just go on a bookshelf. And so from that point onward, I really changed my entire research trajectory and my clinical work to really focus on how do we get the evidence that we have to detect prevent and manage delirium into clinical care. And really that, I did a postdoc at Indiana University, but that brought me to Mayo Clinic because of Mayo's vision that we do what is right for the patient. We always put the patient first.
Wow, that's quite the story. Jen, you want to just tell us a little bit about how you got to Mayo Clinic?
So I actually started at Mayo Clinic as a patient care assistant while I was in nursing school. Nursing was a second career for me. So was fortunate to work all throughout nursing school and really learn how to interact with patients, take care of them, and just love what nurses are able to do and how they can really impact patient care. So have kind of worked my way up and found leadership as a passion. Currently the nurse manager for a solid organ transplant unit. And so thought this was going to be a great location environment for our delirium project and have been truly surprised by the results we've had.
Nikki, tell us a little bit about you.
So I'm Nicole Lies, and I've been at Mayo Clinic for over 20 years. I have kind of an odd pathway. I started in HR in payroll, moved over to finance, and I worked in research finance. And I really loved the research shield and how we are changing the world in research, and decided that I would like to work on quality initiatives within research finance. So I have been in quality type work for most of my career, actually, being inspired by research docs. So, and I will say for me, the thing that I really love about my career and why I continue to do it, I have a CPA and MBA, but I really care about quality initiatives, not only to improve efficiency because the accountant in me likes efficiency, but really to inspire teams to define a shared vision that is like, what would be the best case scenario? And then work towards that scenario. And oftentimes when you have teams that are focused on this common vision that's kind of pie in the sky, they perform so much better. And so for me, I love the work. For me, it's meaningful to impact patients, care teams, and the broader healthcare systems.
So, oh my gosh, you three, we haven't even gotten into our topic.
I'm already inspired.
I just already want to tell you thank you for sharing your stories. They're so inspiring. And that's one of the things I do love about clinical quality work is people draw together from such diverse backgrounds to huddle around what can we do to make care better for patients. And there's so many ways, there's so much opportunity. So thank you so much. But we should dig into our topic for the day. I'm going to just randomly choose Jen to maybe tell me, why did you first get interested in this particular problem out of all the problems out there? And how did you get involved with these other two team members?
Sure. So at the time that this opportunity was presented, I was actually in an interim role as an administrator, and we were looking for a unit that could honestly handle a quality project at that time. And in thinking about the solid organ transplant population, I was thinking, we have liver patients who are encephalopathic, and this is going to be great. But honestly, we've learned that it can impact anyone and everyone. It has no boundaries. And a lot of our patients that have been impacted by delirium are actually our general medical patients. And so seeing that was really surprising for me, but knew we had a great team, knew we had leadership on the unit that could support a project like this. And it would be impactful to both the staff in preventing workplace violence and also to our patients in preventing delirium.
Dr. Lindroth, how about for you?
I got so involved in Jen's answer.
Oh,
I forgot the question.
no, tell us, we know there was this whole work that started to get to where you guys all came in, right? And to work on this problem together. So how did you get connected?
That's a great question. I think I was first connected by Chris Schuler. He had reached out to me regarding delirium because I can't recall how, he saw my name. I'm not sure if he did a search or it was through a colleague, but he had learned that that was my research area. So he brought me in as a research expert along with a few other colleagues across sites to kind of start the initial conversations about, this is what we're seeing in Arizona. This is what we're really struggling with. Where's the evidence on delirium, on how we detect it or how we prevent it, or how do we get ahead of these agitated behaviors so we don't have staff being hurt?
Chris, as you mentioned, was one of our guests on the first podcast on this topic. So I just want to connect those dots for people.
Yeah, there is a natural connection here between
Yeah.
one team figuring out a little bit more detail about what is the problem that we're trying to solve, and then kind of staring around across Mayo Clinic and outside of Mayo Clinic and saying, okay, who can help me solve this problem? And so that's really part of the team. Nikki, how did you get involved in this particular effort?
So I work in quality, and they were having a quality conference, or we have a day that we all meet and discuss what we're going to work on the next year. And Chris Schuler was there discussing this project. And I have been personally impacted by a family member with dementia. And I expressed my interest in the project, that I was really excited that we could make a difference for our patients.
Well, that's fantastic. So Heidi, as you started to help organize this work, I mean, who did you get involved? I mean, we already know several of the people that were involved. How did you begin to envision who you're going to need to help solve these problems?
Yeah, that's a really good question. This group, I think maybe Chris mentioned this in the first podcast, but the group went through a few different iterations and group members over about a 2-year period. And so, like, there was initial kind of discovery, I would call it, phase, where Chris really structured meetings to bring a perspective from different stakeholders, whether they be clinicians, administrators, physician scientists, nurse scientists, Kern Center scientists, to try to understand all the different angles that we could approach the project. I put together a really comprehensive literature review on many different kind of facets to this problem. And what I did to support the group and kind of help me think through what we were trying to solve as well is we did a lot of mapping exercises to map out who is experiencing this problem. What does the problem entail? What are the settings or unique characteristics about it? What do we know versus what do we want to know? And really put together what evidence we have and what might be very tangible pathways or solutions to solve that problem.
And just to interject for our listeners, you correct me if I'm wrong, I think that resulted in a publication in BMJ Open, a systematic review of prediction models for delirium in the older adult patient. Was that kind of part of the fruits of that work?
Yeah, so that actually came before, but that was actually part of my dissertation work. That really helped me build that knowledge base so I could help and support the team and what they wanted to do in solving this problem.
Fantastic. We'll make that and some of the other articles here that have to do with delirium part of our podcast posting, so our listeners can look for those.
Wonderful. And I just want to add, I think, so like that was kind of the first year, that foundation building. However, when Nikki got involved, there was really a synergy that it was like a spark all of a sudden. And I think it was the perfect timing with Jen and the opportunity that she saw, that from that point on, we kind of went from this discovery phase to this, we're going to solve this problem and this is how we're going to do it. And we're going to sprint on it, which was really incredible to be part of and to see unfold.
So Jen and Nikki, let's dig into that a little bit. What did you bring to the table? What were you seeing? Let's start with Jen.
Yes, actually, it was quite organized. And thanks to our quality colleagues, they developed a Kaizen event, which is a 5-day quality initiative, brought our team, quality, providers, pharmacy, everyone to the table to say, how are we going to fix this? How can we make the biggest impact? And so that was really wonderful to be a part of. The team kind of dug in from every angle. What can we do discipline by discipline? And had the support of quality at our side. And then part of the Kaizen event was really reviewing Dr. Lindroth's work. And that was so impactful to the staff. And I think really gave them the desire to do more and to do what they could within their role to make a change.
Awesome. Nikki, what do you want to add to that?
I will reiterate that I think Dr. Lindroth speaking was she's such an passionate person that you just want to go do something about it. And I think that was huge for our Kaizen event. And I think for me, just the motivation to help those patients that are sitting in rooms that are confused, and we don't mean to do things that may be agitating to them, but we do. Our processes aren't necessarily set up to be what they should be for patients in that situation. And so just anything I could do to help, like quality methodology, trying to organize things so that they had the resources they needed so that they could move forward and make the big dent they did. And that 5Es team was very passionate, very energetic. I created a game for them to kind of as an icebreaker that we never thought they'd win, and they beat the time. It was crazy. So very competitive, very fun group.
I just want to pause on that for a moment, Nikki, because your other two teammates have already mentioned how you brought a lot to the energy and the know-how of making this transition from ideas into action. but at least in this conversation, you are the quality improvement expert. I've seen your name on many quality improvement projects. So you become aware that, okay, here's a project that needs doing. You obviously have a little personal passion about it. Share with us your thought process. Is this going to be a Kaizen? Is this going to be a DMAIC? How did you choose to launch this program?
So I will say Judy Henderson was involved in the process. She's the operations administrator over quality. And she was one of the ones that was instrumental in the Kaizen event. There takes quite a bit of buy-in because there's kind of a lot of labor. But you talk about, like, we met at the end of April for that Kaizen event, and we were implementing by the end of the year. That's the difference that can make. And then for me, DMAIC, if you don't know your solution for sure, DMAIC is the best solution because of how you have to get your stakeholder feedback. There's just tools that drive you to create the best outcomes. And there were things we learned that we didn't know prior to going into the project because of that methodology. And so we had some ideas of what we wanted to do, but there was multiple facets that we had to kind of regroup and relook at to be successful, such as the training and the assessments and, just things that we weren't aware that were issues when we first started the project.
Well, share some of those. What were some of the surprises there that you met along the way here?
Well, and Jen, you can add into this because it was Jen's team. Part of it is we were trying to roll out training, and do you want to talk about that, Jen?
Sure. Yeah, one of the things that we realized kind of early on was that our assessment of delirium was pretty inconsistent. The tools that we utilize on the unit to do the assessment can be a little bit complex, and we realized that our nurses just needed more education on how to utilize them correctly. So we had to kind of go back to the drawing board, start our education over again. The team created a new workflow chart that they used to educate every nurse on our unit, and that helped to improve our accuracy of delirium assessments. So that was great to see. That was a real-time fix in the project that we were able to make pretty quickly and pivot and help our project move forward.
Jen, what delirium assessment tool or tools are you using now as this has evolved?
There are several ways we can assess for delirium. First, we would complete a delirium risk assessment when the patient is admitted to the hospital. And then depending on the patient's ability to communicate verbally, the nurse would either use a BCAM, that's the brief confusion assessment method, or the CAM ICU, which is designed specifically for patients in the ICU. Along with that, we perform a delirium triage screen once every shift to catch any changes early. And most importantly, if a BCAM comes back positive, the nurses can immediately begin behavioral interventions to support the patient. How do you feel about that?
That sounded great. Yeah.
Okay.
And that's the whole answer. That's everything.
Yeah. In the other, obviously it wasn't quite as polished in the other one. I wasn't expecting him to ask that question. So I think my response instead of BCAM was BMAT. So it'll be a longer response on this version, if that's okay.
Totally fine. What I'll basically do is go in and grab that response from the previous one, delete it, and put this one in its place.
Perfect. I really appreciate your help. That was super easy.
No problem. Happy to do it.
Thank you. Have a good day.
All right. Bye-bye.
So this is a very complex issue, right? We talked about that a lot in the first podcast too. And so you've done the work that you're doing along the way in the process. So any big challenges that you ran into, interdependencies that you want to share about?
I can share that one of the things we ran into is learning that the order set, which is a little bit out of scope of the project, but that it only had pharmaceutical and like labs in it. It didn't have any behavioral interventions. And that was a big find because that's what physicians are using. And to have this collaborative environment where the nurses are going to be doing these behavioral interventions, we really needed that to tie together. And, that's an enterprise order set. So to get, the buy-in from all the sites and to be able to get that approved, that's been a process, but a very, very important one. And we had a lot of buy-in from some physicians that helped move that along.
Give us a couple of examples of those behavioral interventions that you recognize needed to be added.
Sure. I mean, it can be things as small as reorienting the patient every hour to time and place. And we wanted to do that kind of organically as well. It's not just where are you at Mayo Clinic? What's today's date? Who's the president? Things like that. Today's Thursday. Where do you like to eat breakfast? What TV show would you like to watch? So really stimulating the patient's brain. We talked a lot about medication interventions too, things that we could decrease that would help improve the patient's mentation as well. Things like wearing earplugs and enhancing the sleep process overnight, making sure we're allowing patients to rest. One of the biggest interventions that I appreciate now is getting patients either outside, or if that's not possible, getting them to a room with a window so that they're seeing that natural light. And I sit very close to our team leaders' workstation, and so I can hear our nurses come and advocate for their patients on a daily basis, and that's been really wonderful to see. During the Kaizen event, we were actually able to put together an activity cart with the help of some of our social work team. It's little brain teasers, puzzles, fidget spinners, things like that, things that can help to engage the brain. And we've actually seen some great success with that, where we've got a patient who's maybe escalating to the point where we might need to consider something like a restraint, which is something we don't want to do. And we're able to interact with small puzzles or activity mats, things like that, that help to calm the patient. We've also engaged our PCAs, the patient care assistants, to help with the use of the activity cart. And so that's been really great to have them participate in this project as well.
Let's just take a moment. Maybe I could ask Heidi to comment on this. So you just said, they're getting to the point where we would even maybe have to consider physical restraints. Share with our listeners why that isn't a great solution, because I think, 25 years ago, that might have been a favored solution in some people's minds. So share a little bit of that.
Yeah, absolutely. So what you said is absolutely correct, that over the years, let's say 3 decades ago, the belief was that delirium was a natural part of illness and that it would come in the hospital and it would go away, because delirium does come on suddenly and the symptoms or the behaviors disappear as suddenly. And so somebody could be lucid or with it at 8 a.m. and at 10 a.m. they have delirium, and then at noon they're back to being not delirious. And so it's very difficult as a clinician to see that and recognize it and know how to respond. And many times patients, someone who has delirium, they don't know what's going on. They're confused. They may be having hallucinations and delusions. Those are often fearful and persecutory, mistrustful. And so their reaction to individuals may be to push back, and what we may perceive as clinicians as agitated behavior. So the common practice was physically restraining or chemically restraining those patients. And what we have found over the years is that actually increases the risk of delirium happening. And if it's not already present, or if it already is present, it's going to increase it from, it's going to extend that delirium and it's going to make it worse. And so it's much better to use these behavioral interventions like reorientation, anything to stimulate the brain, anything to kind of restore that sense of normalcy and that circadian rhythm of being up during the day and interacting and knowing what's going on in your environment and what you perceive the noises and light to be, and at night making sure the brain's quiet by wearing earplugs, by trying to maintain that sleep cycle as much as we can. But that's a hard belief.
And so you said a lot of that wasn't actually on the order sets. That is what we're training our young learners to use in these cases. How have you worked to get that on order sets or to make it happen despite what isn't on the order sets? What schemes have you come up with?
I can say that Dr. Daydoni and Dr. Singh have been instrumental in assisting with that. Dr. Daydoni came in from an outside institution and was very much a proponent of making sure that our process flows include behavioral interventions, because you want to prevent, not react. And I think that was a big thing from the whole project that we figured out, is we have to prevent and prevent and prevent. We do not want to react.
That's a whole paradigm shift. Now you think about that.
Are there ways that you've been working to educate your physicians in the hospital more about this so that they are better partners in this care plan?
We've done an entire roadshow as a team. So we call our team on 5 East the Delirium Busters. They presented to many nursing groups, but also to our internal medicine team, the hospital practice subcommittee. And so really trying to get the information out there. We've actually now started talking to other groups within our organization, Minnesota, Wisconsin, other areas that are interested in the work that we've done and how they can potentially do a project similar to that in their location.
So we know this project isn't done, that it's still a work in progress. So, what are your next steps? Where do you go from here? Nikki, maybe let's start with you.
So we continue to disseminate our outcomes broadly. We've communicated within Arizona to the enterprise. Now we're with the Mayo Clinic Care Network, and we get asked to present at multiple other areas. People are so honestly, most people have a personal interest in this because there's some experience they have. We have submitted to present at a national conference. We're waiting to hear back at that, but the work's going to be ongoing, and so that those things will continue. Also, ongoing effort to strengthen collaboration across Mayo. Our work that we did actually hit the nursing flow sheets. It's also going to be in this order set. So this will roll out to the enterprise, our natural work, and we included them in those decisions and what was on it. That Florida has a project that they did in ED that has come over to Arizona. That is the stuff we need to continue. We don't want to duplicate work. We want to expand and grow on the work everybody else is doing. We are also reaching out. We learned about an institution that had some really, really good success with some delirium interventions. And we have reached out to them. I have, and I'm asking for them to meet with us and collaborate so that we can learn best practices from one another and just improve even from where we're at.
So what kind of results has your project had to date in terms of interventions for confused patients or whatever? How are you measuring your progress?
I can share a couple of metrics from the nursing side. So the first, we talked earlier about improving our assessment of delirium. We were able to improve the accuracy of our assessments from the 65% range to above 85%. So that was really outstanding. And we continue to monitor month to month those behavioral interventions. And what we want to see is that those are increasing. Nurses are implementing those more regularly. They're getting them implemented sooner so that we can be more proactive instead of reactive. And we're seeing that month over month.
Fantastic. Right here, there's just such an incredible treasure chest of knowledge and learning, and you're learning across the enterprise. Let's say you're talking to an organization that really hasn't done this much investment in learning about this, and you want to tell them your top tips for where they should start. How should they start?
I think as a group, we kind of discussed why our team has been so successful, and we all agreed we had the right people around the table. We had people that were passionate about making an impact on patient care and who were excited to share that work with others. So I would say make sure you start with the right group.
Fantastic. What would the second thing be?
I would say start small and then scale. Like we had, Jen was a great leader and bringing in her 5 East team. They already knew each other. They already had a relationship with one another. It wasn't this cross, okay, well, we got, this floor and this floor and this floor, and they don't know each other and we're trying to implement something. It would have taken so much longer. So I think start small and scale big.
Fantastic. And how about number 3? Is there a number 3?
So I think I reflect back on this project a lot because every time I hear, I feel like I played a very small part. Sure, I helped do an evidence review. I talked about delirium. I spoke at the Kaizen event, which was so amazing to be part of that. And to see what happened afterwards is just blows my mind every time I hear it. And I think that for me, a number 3 key ingredient would be there's 2 things. One, this group really deeply understood the problem that we were trying to solve. So we weren't wed to a solution, but we were wed to the problem. And then I think the second was the clinicians that were part of that Kaizen event really had the freedom or the autonomy or whatever you want to call it to listen to what the evidence was and then pick what they wanted to make for a solution for their unit. So they were able to localize it to what they needed, and then they just ran with it. I think is a magic component that when you have the right people and you have that right expertise and that interest and that passion, it just is that spark, like I talked about. It's amazing what happens.
Creating the environment and the space to allow that all to come together. I just want to do a really quick plug that we're going to come back to this conversation in a few months because we want to hear sort of the rest of the story and hear how the team is doing work on this. So just for our listeners, be aware number 3 will come in the future.
Yeah, I almost am feeling bad about having to end our podcast for this episode, but to our guests, I just want to thank you all for sharing your work, sharing your insights, sharing your passion and your stories and your determination. The kind of results that you're seeing, I think, really show off meaningful interventions for these confused patients. and improved nursing documentation and all these different things. But even more important than these numbers, I think, is the cultural shift that this work is leading for our institution, treating confused behavior, or should I say, preventing confused behavior, and really kind of leading this work with curiosity, compassion, coordination. So we've come to the end. To our listeners, let me ask, what would it look like to bring the mindset to your unit, your hospital, your system that you've heard demonstrated today? If we can reduce harm, if we can improve care, if we can protect staff through thoughtful delirium prevention and management, then I think we owe it to our patients and our teams to take those next steps. So I'm just challenging you. Thanks for being part of that journey with us. Again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges in your organizations. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, feedback wherever you listen. You can also follow us on your favorite podcast platform. Let others know about the podcast and help spread good information and motivate positive change. Until next time, thanks.